Hello, hi, good evening, everyone. This is Dr. Arbaz, and this is another lecture for the class of 2024 Year 3 students. The topic of this lecture is selection of artificial teeth, and we have covered previously articulators. Before that, we covered maxillomandibular relationship. Before that, we covered orientation jaw relationship. So now, once the upper and lower casts have been mounted, jaw relation has been done, and then we accomplish the teeth setting. So coming to the learning outcomes of this lecture, you are expected to describe the different factors for the selection of anterior teeth. You should also be able to describe the methods for selecting the size and form of the anterior teeth. You should also be able to describe the importance of dentogenic concept, what it is, and who gave this concept and what is the importance of this concept. Next, you should be able to describe the differences between acrylic and porcelain teeth, and you should also be able to discuss the difference factors for the selection of the posterior. Now moving on. Now following the mounting of the cast, as I said, on the articulators and determining the type of the occlusal scheme, the next procedure is fabricating the complete dentures, that is the teeth setting. The anterior teeth are first selected primarily for the aesthetics, while the posterior teeth are selected for the mastication. The type of the occlusal stream generally is dictated by the patient's age, his past history, the type of the ridges he has, whether he has any condition that leads to poor neuromuscular control, and all those things. So moving on. So what is the objective of this selection of the teeth? That is, you should be able to establish harmony with the surrounding tooth, with the type of the tooth mold that you select. You should be able to maintain the vertical dimension that was established at the time of the jaw relation. These teeth or teeth setting should be aesthetically acceptable to you as well as to the patient, as well as it should provide or improve the masticatory efficiency of the patient. After all, many patients seek dentures solely because they can eat properly again. Then, the first factor for the selection of the anterior teeth is the size of the face and the head. That is, there are many authors have given different guidelines, that is depending on the bizygomatic width, depending upon the circumference of the head, depending upon the interpupillary distance, interalar distance, distance from the commissures of the mouth. We can gauge the width of the anterior teeth, that or what width of anterior teeth we need for the teeth setting. So here's one. The average combined width of the maxillary anterior teeth is determined by dividing the bizygomatic width. This is the bizygomatic width, that is from the posterior to the corner of the eye. This is called as a bizygomatic width, and dividing it by 3.3, we can get the width of the anterior teeth, that is from canine to canine. So this was given by. Another measurement is a measurement of the circumference of the head. It is stated that the circumference of the head between the glabella and the occiput is a guide for determining the width of the maxillary central incisor. So if once we measure the circumference from the glabella to the occiput, we divide this by 16 and we get the measurement for the maxillary central incisor. Okay. So the next is the ratio of the cranium. So sorry, the cranial width, that is from the cranium glabella to the occiput, is in a ratio of 10 is to 1 to the width of the upper anterior teeth. So if this is x, then the width of the upper anterior teeth, that's from maxillary canine to maxillary canine, will be x divided by 10. So this is the width of the maxillary anterior teeth, and this will be determined by measuring the distance from the glabella to the occiput. So this is in the ratio of 10 is to 1. So next is by the use of anatomical landmarks. You have already done the jaw relationship. Markings are placed on the corners of the mouth, that is commissures of the mouth, in the wax occlusal rim, extending vertically parallel to each other. Then this measurement is measured using a flexible ruler, and this ruler or this measurement will be a guide for selection of the size of the or the width of the anterior tooth mold. So here it is, we measure this, and then this measurement is then correspondingly measured on the tooth mold that we want that corresponds to this measurement, and once we get the measurement, we can then decide on the form of the teeth that we need to select for the particular patient. That's it. So this is the mold that was selected for this patient because it was equivalent to the measurement from the corners of the mouth, and then the tooth mold can be. So parallel lines are extended from the another thing is parallel. Another way of measurement is by in measuring the inter-alar distance. Parallel lines are extended from the lateral surface of the aloe of the nose onto the maxillary occlusal rims, and this will give us a measurement of the apex of the canine. So this inter-alar width corresponds to the width between the canine tips on either side. So simply put, we mark the smile line, we mark the midline, we mark the inter-alar line, and the canine tip will correspond to the terminal portion of the inter-alar line as shown in this figure. So next, incisive papilla also serves as a guide for determining the anterior teeth selection. We should draw a line through the distal border of incisive papilla perpendicular to the midline of the palate, that is passing through the mid palatine raphe, and on this line the tips of the canine will lie. So by locating the incisive papilla and drawing a line through the distal of the incisive papilla perpendicular to the midline of the palate, we can determine the mold or the circumference of the anterior teeth that are needed for the teeth setting. Okay, so next thing is if the edentulous patient has prominency in the buccal bone in the canine region, that is, if patient you can mark out the canine prominence in the patient like over here, then we can measure the distance between the intercuspid prominence and we can select the width of the anterior tooth mold that we need. Or else if the canine prominence is not there and patient generally will have buccal frenums on either side, so we can use the buccal frenum as a reference for selecting the or measuring the width of the anterior teeth. Usually the buccal frenum will lie just distal to the maxillary canine, so this serves as a good reliable reference for the selection of the anterior teeth, as you can see over here. So we can arrange the teeth then according to this width or according to this information. Next is the based on maxillomandibular relationship. In class 3, as we all know, the mandible is large, the maxilla is small, therefore the mandibular anteteeth are selected which are larger than normal. Whereas in class 2, the maxillary arch is bigger and the mandibular arch appears smaller, so we have to select mandibular anterior teeth which are smaller than normal. So in class 3, we'll set a larger tooth mold for the mandibular anterior teeth, whereas in class 2, we'll select a narrower and more longer tooth mold in case of a class 2 for the mandible. Next, contour of the residual ridges. As we all know, the artificial teeth should be placed to follow the contours of the residual alveolar ridges when the natural teeth are present. Thus, the size of the anterior teeth is selected according to the position of the residual alveolar ridge. So, with age and with residual alveolar ridge resorption, the maxilla resorbs in a vertical and in a palatal direction anteriorly, and posteriorly it resorbs in a vertical and medial direction. Whereas the mandible resorbs in a vertical and lingual direction anteriorly, and posteriorly it resorbs in a vertical and buccal direction. So in a sense, with resorption the mandible becomes larger and the maxilla becomes smaller. So if D is the resorption after 10 years, so this will be the final topography or the morphology of the maxillary residual ridge, whereas the mandibular residual ridge would have reduced only in height, maintaining its circumference or becoming slightly larger. Whereas the maxillary ridge from here, that is 10 years back, if this was at A, point A, after 10 years it has moved so much back that is still point D. So in such cases the contour of the residual ridge will allow us to determine whether we use a larger or a smaller anterior tooth. Also, the shape of the residual alveolar ridge in general will also help us in guiding the form of the anterior tooth to be selected. We all know we have three types of arch forms, that is square, tapering and ovoid. So depending on this we will select the tooth form that best corresponds to the arch. So if we see a square shaped arch, we will select a square shaped tooth mold. If we have a tapering arch, we'll select a tapering tooth mold. And if we have an ovoid arch, we'll select an ovoid shaped tooth mold. Next, coming to the lips. Lips also serve as factors in the selection of the anterior teeth because lips will generally determine the height of the anterior maxillary occlusal rim. So, depending on the height, we can select a longer or a shorter tooth mold. In females, generally a 3 mm display of teeth is preferable, whereas in males, a 2 mm display is preferable. Whereas in elderly patients, a 0 to 2 mm above the lip line. That is, in elderly patient at rest, there should be no visibility of the upper anterior teeth because in elderly patients, the lips generally droop, the lower teeth become visible, and the upper teeth are hidden from the to the person viewing them. So this is according to lips. We can select the height of the anterior teeth. Next, coming to various other methods like pre-extraction records, such as facial photographs of the patient with their teeth when they were young. If previous diagnostic casts are available, if any radiographs like profile silhouettes or lateral steps are available, we can view them to get an idea of the type of the teeth that we may require or we may select. So these are just general arbitrary guidelines. There's no concrete scientific proof to it. They can aid us in selecting the anterior teeth if you are in a doubt. Even the teeth of their close relatives such as a son or daughter, or if patient is undergoing extraction and construction of immediate dentures, then we can look at the teeth that are being extracted to get an idea of what type of tooth mold would be best for the patient. So next, form of the face. Just like the form of the arch, the form of the face is also divided into square, tapering and ovoid, and similarly we can select the tooth mold based on the form of the face. This was first given by Leon William. Next is similar to the face form, we can also view the profile of the face to get an idea whether patient has a convex or a straight facial profile. And depending on that, we can select a tooth mode with a more convex contour or with a more flatter contour, as you can see over here. So these are ruthenium acryrock tooth molds. So depending if a patient under convex profile, we can select teeth which has a more convex facial profile, and if a patient has a straight or a flat facial profile, we can select teeth with a more flatter facial prominence. Next, coming to the dentogenic concept, which was first advocated by Fresh and Fisher in 1957. This is based on SPA concept, that is sex, personality, and age of the patient. So the SPF concept takes into account three factors, that is, as I mentioned, sex, personality, and age. So according to sex, curved facial features are generally associated with femininity, as we all know that we have been conditioned to believe, and through media, through through advertisement, through the internet, that generally we associate curved features with femininity, and we associate square features with masculinity. So to create harmony between the tooth form and the face, females will generally have a tapering and ovoid tooth mold selection, or based on the femininity, and males will have generally a square shaped tooth mold selection to display or to show masculinity. Next is the color. We can also look at the patient's color of their hair, eye, and skin to decide what type of tooth mold or tooth shade we need to select. Individuals with blue, green, and light colored eyes, generally Europeans and North Americans, will tend to have a lighter teeth shade, whereas those with darker skin and will have, or darker eyes will have, a darker teeth shade. So this is what is given in text, but in my personal opinion, over the past 17 years that I have been working as a prosthodontist and as a prosthodontic specialist, I have generally seen that people with darker skin complexions and blacks or Hispanic people will generally have more whiter teeth rather than darker teeth, and generally Europeans, North Americans, and Scandinavians will have a more a darker tooth shade like a C or D tooth shade. Next is the age. With age, the teeth color also becomes darker because of the erosion and abrasion and attrition of the teeth, which results in wear of the enamel, and this results in display of the dentin, which is more elevation color. Also, with age and habits, the teeth tend to become darker because of consumption of tea, coffee, and consumption of tobacco-related products. So with age, we generally prefer to give a patient a darker tooth shade, something like A3 or A3.5, and a younger individual we would give a shade which is more lighter, like an A1 or A2. The sex also again will determine. Males we generally tend to have a darker shade, whereas females we tend to prefer to give them lighter shades because it is a general preference by them also. So next, coming to the selection of the posterior teeth. Up until now we were talking about the selection of anterior teeth based upon the SPA concept, based upon the form and features of the face, and based upon the color of the hair, skin. And now we come to the selection of the posterior teeth. One key factor to be remembered in selection of posterior teeth is the buccolingual width, the mesiodistal width. So buccolingual width generally should be sufficient to act as a occlusal table to hold and chew the table, that is masticate. After all, that is the primary function of the posterior teeth, that is bicuspids and molars are used for gnashing, gnawing and masticating the food. So generally uh, buccolingual weight should be suitable to act effectively in the mastication of the food. But buccolingual weight should also be such that it should provide sufficient support or to the facial musculature, to the tongue, resulting in a stable denture. So here you can see the next thing is buccolingual width of the artificial teeth should be slightly less than that of the natural teeth. So if this is the natural tooth contour, the artificial tooth should be smaller than the natural tooth, being replaced for the stability of the denture, as well as the fact that if a patient has been edentulous for a long time, the tongue grows in size and the cheek lose their tonicity, thereby reducing the corridor where the teeth need to be placed. Next is when the lower ridge is strong, that is, we have tall, well-rounded ridges, and with which is sufficiently covered by thick stratified squamous epithelium or the attached gingiva, then we can have or afford to have teeth which are larger in their buccolingual width. But if we have knife edge ridges or flabby ridges, then we cannot have larger teeth. We should select buccolingual width based on a smaller tooth mold. The next factor is the mesodistal width, that is the width from the cuspid eminence to the slope just anterior to the retromolar pad. So this mesodistal width will determine the size of the tooth mold that is selected for the posterior teeth, that is the bicuspid, the first and second premolar, then the first molar and the second molar. The posterior teeth, that is the second molar, cannot come on the ascending path or cover the retromolar pad because this will result in instability and dislodgement of the denture. So, and these measurements are really important in class 2 and class 3 ridges, because as we know, in class 3 ridges we have a large mandible compared to a smaller maxilla, so we can afford to use a larger tooth mold, whereas in class 2 we'll have a smaller mandible compared to a larger maxilla, so we have to select a tooth mold which is smaller, or we may have to skip one of the bicuspid, or like we may skip a first premolar and directly place a second premolar adjacent to the canine if the width is not sufficient to place all the four posterior teeth. Now coming to the occlusal gingiva, of course the inter-arch space is very important for the selection of the tooth mold. If we have sufficient inter-arch space, then we can select a larger tooth mold. But if we have restricted inter-arch space, we will have to select a shorter tooth mold, or we have to grind the teeth to fit into the inter-arch space between the parallel ridges. Next is the form of the teeth. So once you have selected the tooth mold, I think depending on the buccolingual mesodistal width, we also need to take into consideration what type of occlusion we'll be giving, and based also on aesthetic. Like we have generally two categories of posterior teeth. They are classified as anatomic and semi-anatomic and non-anatomic. So basically, semi-anatomic also are a part of non-anatomic teeth. So anatomic teeth are called as cusp teeth because, of course, they have cusps, and they are designed to simulate the occlusal surface of the natural teeth and to effectively grind and chew the food. So they generally have a cuspal inclination of 33 degree. Semi-anatomic teeth are slightly smaller than anatomic teeth. That is, they have a more shallower cuspal inclines as compared to the anatomic teeth. Here, the cuspal inclines are generally about 20 degree, whereas in anatomic teeth they are about 30 degree. So, what are the advantages of these anatomic or semi-anatomic teeth? Of course, they are aesthetic. They look good. If patient has a large smile that exposes all his posteriors up to the first molar, they are more efficient cutting and incising the food because of the sharp cusp. The cusp make contact in the fossa in the centric relationship position, and this is a comfortable position and a point of definitive return. So, because of the cusp, the patient's teeth go easily or are guided exactly into the centric for relation, and they don't slide very easily over each other. So it is a definitive confirmation for a centric relation, and they are primarily selected for the arrangement of the teeth in balanced occlusion, so that when the patient performs excursive movements like protrusion, retrusion, left and right excursive movement, the upper and lower cuspal inclines will be in simultaneous contact with each other in any direction and will create a stable prosthesis. But the disadvantages are that the presence of cusp generate more horizontal forces. And in cases of ridges with a short or knife edge ridges or with ridges with effused tissue, this will result in instability of the denture and trauma to the tissues. Second thing is harmonious balance occlusion is lost when the settling of the denture base occurs. So some authors like Devan stated that even though we can do a good balanced occlusion in a complete denture and give to the patient, over a period of time, settling of the denture base occurs over the tissues. That is the mucosa covering the residual alveolar ridges, because after all the mucosa is made up of 80 to 85% of the water, and based on Pascal's law, the when the pressure is applied, it is applied throughout the area, and this can result in settling of the denture base, and this may compromise the balance occlusion. So next are the non-anatomic teeth. As the name suggests, non-anatomic teeth are also called as cuspless teeth, monoplane teeth, or zero-plane teeth, because zero-degree teeth, because they do not have any cusp. They essentially have a flat occlusal morphology with maybe pits and fissures. So these teeth are, as you can see here, these are the monoplane or a non-anatomic teeth. So they are have zero cuspal inclines, and just they have some grooves and fossae to aid in the chewing of the food. So some authors or sometimes they may also need to use these teeth in a combination. That is, we may use anatomic teeth in the maxillary arch, and we may use monoplane or zero-degree teeth in the mandibular arch. And this concept has been long practiced in Europe and parts therein. This was first advocated by Dr. Alfred Geisy, and this concept is known as lingualized occlusion, in which only the palatal cusp make contact with the central fossa of the mandibular posterior teeth, which have a flatter cuspal inclines or zero-degree teeth. And we also have certain manufacturers that manufacture specific teeth for these type of occlusion, which are known as ortholingual, that is for lingualized occlusion. Now, this type of scheme is generally we reserve for making implant processes, implant hybrid processes, and implant fixed restorations, and also for certain cases of where we do not have very good ridges to give stable complete dentures. So advantages are there. These are the advantages of the non-anatomic teeth. So the advantages are that they are less damaging than cusp teeth, because when they are not arranged in balanced occlusion. So of course these teeth do not have any incline, so there is no balancing. They are always in contact with each other. The force of the four, they offer less resistance to horizontal forces because they don't have any cuspal incline, so there is minimal resistance to horizontal forces, and thereby minimum transfer of the stresses to the residual ridges. And they are especially useful in cases of bruxism, as I mentioned, poor residual ridges, and in class 3 and class 2, man-related jaws, and patient with uncoordinated neuromuscular control. Most of the time, when patients are very old in their late 70s or 80s, or they have suffered stroke, they will have poor neuromuscular control, and of course patients such as patients having Parkinson's disease or trigeminal neuralgias, or who have had different degrees of stroke, and they cannot maintain or stabilize the jaw for a long time in a particular position. So in such cases we cannot give anatomic teeth, as there is no point in giving such teeth. They will create more horizontal forces, so zero degree teeth are efficient in such case. But the main disadvantage is, since we do not have any cusp, the sharing or the masticatory efficiency is reduced in such patients. Patient has to put more effort to grind the teeth, grind the food. So this is the major drawback of non-anatomic teeth. Of course, they are also not too aesthetic. So this brings us to the end of this lecture. This was a short lecture about selection of teeth. So artificial teeth should be selected for aesthetic as well as function. The size, form, and color play an important role in the selection of the artificial teeth. While aesthetic this dictates the selection of the anterior teeth, the type of the occlusion planned will determine the posterior teeth selection. Anatomic teeth are generally used specifically when balanced occlusion in centric relationship is desired, whereas non-anatomic teeth may be used in specific conditions as I just mentioned. With the advent of highly cross-linked resin teeth, the use of porcelain dental teeth has now become a rarity. So we never see porcelain teeth being used nowadays. So most of the time we are just using acrylic teeth or high impact resin acrylic teeth, or IPN, that is interpenetrating polymer network teeth. So that brings us to the end of this lecture, and I'll see you again with another presentation.